All right, let's talk about respiratory dysfunction, cystic fibrosis. Cystic fibrosis, by definition, is an exocrine gland dysfunction that produces multi-system involvement. The difficulty with it is life-shortening. It is a recessive trait, and you can kind of think of increased mucus production in all of those systems, which we'll also talk about a little more in detail. So the pathophysiology, it's characterized by these elements: increased viscosity of mucus gland secretions. So if you think about mucus gland secretions, then you can think about some of the clinical manifestations in the systems. Cystic fibrosis results in mechanical obstruction. Thick mucoprotein accumulates, coagulates, forms secretions in glands and ducts. The respiratory tract and the pancreas are the organs that are the most affected. The most reliable diagnostic procedure is the sweat chloride test, and that comes from the elevation of the sweat electrolytes, one of the pathophysiological manifestations. Sodium and chloride levels are 2 to 5 times greater than those who do not have cystic fibrosis. And then you have increased organic and enzymatic constituents of saliva are seen. And then abnormalities of the autonomic nervous system are present. This is a really nice picture depicting the systems. So you see in the bronchi, you have generalized obstructive emphysema, chronic bronchial pneumonia, and this is, again, that increased mucus secretion. The small intestine, you can have intestinal obstruction in the newborn when the child is born, or you have just increased mucosa sloughing in the intestine. Pancreatic ducts, secondary degeneration of the pancreas, a problem with the pancreatic enzymes, and this can lead to the child unable to absorb correctly and can lead to malnutrition. And then your bile ducts, this can lead to portal hypertension. The thick secretions that are in the biliary area can cause biliary cirrhosis and hypertension, portal hypertension. So you have a pancreatic enzyme deficiency, progressive chronic obstructive pulmonary disease associated with infection. So this is the COPD can occur in people who have cystic fibrosis in the youth, or those who have the antitrypsin for youth COPD. Otherwise, COPD is considered a injury component. So also clinical manifestations: failure to thrive, as we talked about with the malabsorption, increased weight loss despite increased appetite, and then the gradual respiratory deterioration. Because the pancreas are one of the main organs involved, 50% of patients with cystic fibrosis end up with diabetes. Some of the manifestations are severe insulin deficiency, beta cell dysfunction, insulin resistance. With the gradual respiratory deterioration, the better nutrition the cystic fibrosis client has, the better increased pulmonary function. So the child with cystic fibrosis has wheezing, respiration, dry, non-productive cough, obstructive emphysema, cyanosis, clubbing of fingers and toes that occur with long-term chronic respiratory conditions, repeated bouts of bronchitis and pneumonia, just inability to clear secretions. Meconium ileus, prolapse of the rectum, distal intestinal obstruction syndrome, excretion of undigested food in the stool, and this is due to the biliary not working correctly, those enzymes not working, and then wasting of tissues. Females can have delayed puberty, males can be sterile. Parents report the children taste salty. Why, why, you're wondering, would parents taste their children? And that's when you're kissing and hugging them, or in general, when you have a baby that's so adorable that you want to eat them as a parent, they may taste a little salty. Because of this electrolyte imbalance, the child can be dehydrated, low sodium, hypoalbuminemia. The absolute gold standard is the sweat chloride test. You will need to know that for the exam, and the stool fat or enzyme analysis. The barium enema just looks at the mucosal area of the biliary tract. Pulmonary function tests will tell you the management of the respiratory portion. So moving to respiratory manifestations of cystic fibrosis, present in almost all cystic fibrosis patients, but the onset vary and the extent vary. So the secretions are difficult to expectorate and can obstruct the bronchi, leading to more increased bronchitis, pneumonia, atelectasis, and hyperinflation. So decreased oxygen and carbon dioxide exchange occurs, resulting in hypoxia and acidosis. Long-term can lead to cor pulmonale, respiratory failure, and death. So we also know if one can't clear secretions, then what happens? You can get infectious pathogens. So these are some of the bacteria and infectious pathogens that can colonize, and the infection is very difficult to get rid of. So the respiratory progression follows chronic infection. So the goal would be, this is a child that's going to be getting a pneumonia vaccine, going to be getting, making sure that staying on the immunizations to hopefully prevent these complications. We talked about that. In their GI tract, thick secretions block the ducts, leading to cystic dilation, degeneration, diffuse fibrosis. So the intestines were not able to do the job of getting the nutrients from the food that's passing by, and the food just passes by. And impaired digestion, no fat is able to be absorbed, protein is unable to be absorbed, and so you have malabsorption. Endocrine function of the pancreas is initially unchanged, but then fibrosis occurs, resulting in 50% of the patients with cystic fibrosis getting diabetes. Biliary obstruction can occur, impaired salivation, another clinical manifestation. Treatment goals are to prevent or minimize pulmonary complications, and really assisting with nutrition. Assisting a child adapting in chronic illness. The lifespan is generally around age 40 for clients with cystic fibrosis because of all these complications. Chest physiotherapy can help with the mucosal and the secretions moving. Bronchodilator medication can help. Forced expiration can help those alveoli. Aggressive treatment of any pulmonary infections. Here's just an example of a child using a flutter mucus clearance device, and this can help with like chest physiotherapy. You want to prevent pneumothoraxes, of course. Steroids or non-steroidal anti-inflammatory drugs can help pain. Transplantation, if the child can be on a lung transplantation, then there can be better outcomes. But survival rates, again, are 40 years, and approximately 50% of patients are 18 and older. So this is a a young disease and unfortunately high mortality. So your management for cystic fibrosis for the GI area, replacement of the pancreatic enzymes, high protein, high caloric diet, maybe even 150% of the recommended daily allowance. You're treating constipation because of that. The patient with high protein, high caloric diet is going to be at risk for constipation. And then also that electrolyte imbalance, right? So if they're dehydrated and high protein diet, that's an equation for successful constipation. Reduction of any rectal prolapse, supplementing them with salt, they are hyponatremic, right? And then any other clinical manifestations such as gastroesophageal reflux, just from the lack of motility. Endocrine management, you're monitoring their blood glucose levels, you're working on diet, exercise, and regular eye examinations just because the child is at risk for diabetes, has portal hypertension, they may have ocular problems as well. Okay, we talked about the prognosis. Continues to be a progressive, incurable disease. The organ transplantation has increased survival rate, and to maximize the health potential, where you're really looking at nutrition and prevention of comorbidities. The emotional needs of the child and family. The child requires treatments multiple times a day, frequent hospitalizations. There are lots of support groups for families with children with cystic fibrosis. Let's go through this one case study. During the first visit to the pediatrician for a 2-day-old infant, the nurse performed a complete physical assessment. The nurse noted and reported to the physician the following concerns: weight loss of more than 10%, slightly distended abdomen. Mother reported no stooling. So you remember a 2-day infant should be passing meconium, and weight loss should be no more than 10%. What other information should the nurse gather? Obtaining genetic history to know if cystic fibrosis has occurred in other family members, since it's a recessive condition. Ask if the infant tastes salty. Talk about any feeding schedules, and have there been any respiratory problems. After a diagnosis of cystic fibrosis has been made, the infant develops a respiratory infection and is hospitalized. What are the priority nursing interventions? Well, you're going to provide education on preventing infection, regular chest physiotherapy, bowel management, medication needed for the clinical manifestations, adequate nutrition, and prevention of exacerbation, and you're providing family support. What specific information can the nurse provide to the family that will help prepare the family for home care of their infant? You're going to teach the family how to mix the enzymes in a puree and feed it with a spoon. So this 2-day child, will need enzymes, and we know that 2-day children, so this child will need to be put it in a puree and bottle fed, either with their nutrition supplement. Caregivers need to know how to remove mucus, monitor glucose levels, and anticipatory guidance for any developmental anticipation. What information can be provided to the parents in regard to the possibility that future children may have cystic fibrosis? So you're looking at genetic screening for any recessive traits. Okay, that concludes cystic fibrosis.